Hello and welcome. I'm Tafara Gadamu. My guest today, Dr. Sanait Fasaha, has been and continues to be instrumental in the training of Ethiopian medical doctors. This she is doing by creating a solid link between the University of Michigan in the United States and the St. Paul Millennium Medical College here in Ethiopia. But what's new here? A very warm welcome to the program, Dr. Sanait.
Thank you.
When I was researching this story for this interview, I came across one Facebook posting, actually, on Dr. Tedros Adhanom's Facebook page. He used to be the Minister of Health before he assumed his current position. And I knew you knew each other from that time period. And he wrote this. Thank you so much, Sanait, and the University of Michigan, for all the wonderful support to improve the health system of our country. Well, what is lacking in this country as far as the health infrastructure is concerned, do you think?
Well, there's a lot of good stuff happening, and there's a lot lacking. I think like most countries, especially in the global south. What we have going for us is we have great leadership. We have leaders with vision, with commitment, and I think we're doing okay with resources. I mean, they're great in mobilizing resources. We need to continue to strengthen our health system. We need to continue to work on strengthening and developing our human resources for health. That is our doctors, our nurses, our midwives. So there's a large initiative at the country, and started with the leadership of Dr. Tedros and now taken over by Dr. Kasete. They're really moving us in the right direction in terms of going from acutely working to reduce preventable deaths, by infection, by birth-related death, to addressing chronic diseases. And we're doing that by building the health system, by building infrastructure, hospitals, acquiring equipment, training specialists, training generalists, mid-level providers, and so on.
So you're talking about human resources and facilities that would definitely host doctors that are trained to work in those facilities. Am I correct?
Absolutely.
Mm-hmm. Now that brings me to your $25 million that you got from a very anonymous source. Is that the fair?
Correct. Yes.
And you are interested. I know you've started this project of training Ethiopian doctors and others in the health sector. But this is a massive departure from what you've been doing in the past, right? Because you now have the financial muscle to be able to get the Center for International Reproductive Health training in this country to a much higher level.
Correct. So I did start working in this country as an individual, as an Ethiopian who lived abroad and had the opportunity to be working in a great training institution that was committed to help me support my vision and goal of working in Ethiopia. So I've worked in academic institutions, training or supporting the training of physicians. I've always been committed and continue to be committed to women's health and reproductive health. So, in fact, one of the very first postgraduate training program we started was to train obstetrician gynecologists who can take care of women across their lifespan.
That was way back in 2012, right?
Correct. So, in fact, I started coming here as a medical student. I started coming here through a group called Ethiopian North American Health Professional Association, or ANAPA, and I think the founder was once your guest, Dr. Ngida Asfaw. So through the years, I've been coming, and all my relationship and engagement has been in academic institutions. But I am, my specialty is an obstetrician gynecologist with further training in reproductive endocrinology and infertility. I do believe access to family planning is the cornerstone of good reproductive health care, reducing maternal mortality, empowering women to make their reproductive decisions, to give them the economic freedom so that they choose when and where to have their child, and also be able to, do it at a time that's convenient for them. So even when I work with GPs and other specialists, we've always been addressing family planning. But you certainly are correct in a sense that being able to get this large grant will now allow us to align that goal with that of the Ministry of Health and incorporating a strong reproductive health training into general practitioners training, into the training of our obstetrician gynecologists and other practitioners, so that this becomes a core competency that our healthcare providers develop.
So you are into training and not into service provision, right?
Well, they sort of go hand in hand. So when you train doctors, invariably they end up giving service, and when you train them, like so academic institutions usually have what we call a tri-mission, or tripatriate vision, mission and commitment and goal, which is research, teaching, and service. So they sort of go hand in hand and enable. So by working in academic institutions and strengthening the capacity of those institutions to produce doctors and nurses and midwives that are better trained and better equipped, you're ultimately producing people that are providing service. And during the service provision, during the service provision, you're doing teaching, and during learning, you're giving service. So they're really intimately integrated. I mean, there are situations where you could be in a private health institution where you're just primarily giving service, but almost all academic institutions combine those different elements.
The University of Michigan and you in person have partnered with the ministry, through the Ministry of Health, of course, the St. Paul
Correct.
Millennium Medical College, right?
Correct. So the relationship is such that, so I do represent University of Michigan, but there's a huge institution that has 37,000 employees behind me, and their commitment has been just outstanding. So it was Dr. Tedros who saw sort of my individual efforts scattered throughout various programs, and we were having these conversations, and I was telling him, I really want to do something meaningful and sustainable, and he said, why don't you start working at St. Paul, this relatively new medical school that was only in its fourth or third year when I started, and more than anything had just amazing leadership. The former provost, Dr. Vesvanar, as a psychiatrist, a prominent psychiatrist, was the provost, and Dr. Leah Tadessa, who was on your show recently, is just this remarkable young woman who has just committed all her time and effort and energy to help shape the future doctors in this country. So it was just an opportunity that just fit perfectly with what I wanted to do, and also an environment that made it very easy for me to integrate my work and to be successful. So I started collaborating with them, and we started working on supporting medical education and expanding postgraduate training programs. And the reason for that is, multifold. One is
That was where I'm driving at.
Is that right? Yeah.
Walk me
Yeah.
through the specific training that you provided.
Absolutely. So we
It's tailor-made, I don't know.
Right. So we work on medical education. St. Paul has a very unique curriculum in the country. It was one of the earliest programs that the Ministry of Health started, and I find it fascinating because
What makes it unique? Because
what makes
several medical
colleges
spread out across the country.
There are, throughout the world, in most parts of the world, medical school lies under Ministry of Education. I think, as far as I know, Ethiopia is the only country where Ministry of Health have said, we're going to start establishing medical schools under Ministry of Health in partnership with Ministry of Education. And for me, that makes perfect sense, because the Ministry of Health is in charge of the health of the community. So to have a unique program where you understand the health of the community, the needs, the healthcare needs of the community, and be able to devise a curriculum that reflects that need, helps you produce doctors that then can go out and meet that need, instead of just following whatever curriculum is designed out in the West or somewhere else. So I thought it was a brilliant move. St. Paul was the first school that started under this curriculum. So it's a 6.5-year curriculum. We take students from undergrad, but instead of being assigned like they do in most schools based on their performance, they have to apply specifically for the school. They have to take an entrance exam, and they have to have an interview. So it's a very unique process. We also are committed to producing doctors who are from the emerging regions. So we preferentially take students from those regions as well as women.
But they have to compete for
They have to compete, absolutely. We will take other things. Our early observation, and we have some data, shows that if you take students who meet the minimum criteria and go through this rigorous process, even if they are not the 4.0
you can work on the rest.
They in fact end up surpassing the students who have higher grades. So they, you nurture them, you work with them, you mentor them. They do that, and they go back to their communities.
But that's quite an investment, isn't it? Because you're not having ready-made kids.
It's quite an investment. I mean, some of them come from rural areas. They may not have the language skill proficiency, others do, so they end up taking English as an addition to the classes they are required to take for medical school. It's an investment, but when we look at our students, it's a worthwhile investment. Our first class graduated, in fact, a year ago this year, November 12th, 2013.
Was their first degree?
That was their first degree. And I was talking to our health minister at one point. He said to me, right before graduation, they have a 2-week time they spent pre-deployment training at the Ministry of Health. And the minister gives every student his cell phone number. And he will say, when you go out in remote areas, if you have any challenges, call us. We want to hear from you, whether it's personal, whether it's professional. We want to hear from you. We want to support you. So he said if he gets phone calls from students that are graduated at St. Paul, 9 out of 10 times, they're calling to say there is something we could do to fix the health system. These are the challenges we have identified. We can do ABC. They really, so we're training not only just doctors, we're really training leaders. So in spite of all the investment and the effort it takes, we're extremely proud of our graduates. I think they're going to be the ones, I strongly believe, who will be shaping the future of this country.
Interesting. What about the others? The other universities?
Of course, no, absolutely. The others have, I can't speak in depth as I can about St. Paul, but I'm sure they have outstanding curriculums. There are challenges. Our schools have challenges. We don't have enough teachers. We have a lot of students. The student number is quite high. We worry about, ensuring that they get adequate cases before they graduate. But parallel to that, there are many, many initiatives the government is putting in place, adding simulation training, adding licensing exams, other things to ensure that quality doesn't suffer, but certainly...
What about postgraduate education? You haven't had your first batch yet, right? Graduates.
So there are many postgraduate programs in the country, Addis Ababa University being the lead for the oldest and the more... both depth and breadth of postgraduate programs in the country. But having a country of 90 million people, certainly that's not going to be enough. You need a lot more than what we have now. So we did start expanding postgraduate training program at St. Paul. The first one was OBGYN. Our first batch is in their 3rd year. Again, they have a very unique competency-based curriculum. It's not just counting the year, but we ensure that they're competent in every set goal that we have set, for them.
You want to train 50 of them in the next, 4 years? Is that the plan?
Well, we right now are taking 15 a year. With the first 515. The first year we took 7 a year, and then went up to 15 a year. Right now, because we have the resources, there is massive interest, both from students, because we're now producing large number of GPs, so there is a huge need for opportunity to go into postgraduate training program, and the support of the ministry. We have unprecedented support to work with ministry to expand our training. Right now we're in the middle of assessing universities outside of St. Paul. We're looking at potentially 12 to 13 sites where we either expand current existing residency program in surgery and OBGYN.
So you have started the conversation already?
So we have. In fact, we have more than started the conversation. Ministry is the lead on this. We have already formed a technical working group. There is a time frame in place. The professional societies are quite engaged. The Surgical Society of Ethiopia, led by Dr. Milliard, Dr. Abeba, are actively engaging and pushing to train more surgeons. If you look at the data, right now the ratio we have is about 1.8 million women for one OBGYN and 1.6 million, per one surgeon. So it's really, it's really atrocious numbers. So we can't continue. In fact, Dr. Milliard shared this data with us that if we continue to train doctors at the pace that we're doing, we're going to need another, I think he may have said 50 or 60 years to be able to meet it. So we do need, there is a grave need to increase the numbers, but we also have to ensure quality. So I'm just so pleased to see academic institutions, ministry, professional societies all coming together to expand and train, especially this critical workforce of surgeons and OBGYN.
So you think yours a new model, you think?
Oh, I think so. I think it's a brilliant model. I think academic institutions have always been primarily responsible for being in charge of postgraduate training program, and I don't think that's changing, but to be able to have those academicians reach out to their professional societies and reach out to government and be in the driver's seat to say, this is where we are, and we need to pick up the pace and work harder and work faster to have meaningful intervention.
So how easy is it going to be, or I don't know, how difficult is it going to be, I mean, in terms of replicating the model that you have in St. Paul Hospital elsewhere in the country? For example, Black Line Hospital.
Well, Black Line does not need to replicate St. Paul because they already are doing a lot of things, and they're doing them very well.
But you just told me that it's unique and there's something to it.
Absolutely, it's very unique. I think there is always dialogue. For me, I don't settle where I am. I always ask myself, saying, can I do better? So because I work at St. Paul, I have this unique advantage of, admiring and advertising and saying and kind of, singing the praise of St. Paul because that's what I know. But I also compare it to the curriculum that I went through in the U.S. And I have seen the curriculum in other institutions, and I really think it's a unique curriculum that we all should stop and say, should we push ourselves and look at this curriculum compared to our traditional curriculum? And I think you always do better as an institution, as a person, as a country, when you challenge yourself. And I think St. Paul is at that crossroad where can challenge other institutions, saying, let's look at our graduates, let's look at their perception of their education, and I think we need data to do that. Physicians are scientists, so they need data to change their practice. But I think now that we have seen this, we have to start assessing and evaluating and gathering data to say, how are physicians trained in different curriculums and different settings performing. We need performance metrics, and I think that will guide us. That will guide us whether we should change, we should stick to, or really take the students from St. Paul and put them in traditional curriculum.
So without the money that this time around came from an anonymous source, I don't know who that is, but it's an obscene amount of money. Without that money, we wouldn't have done anything. We wouldn't have started to dream.
I disagree. I disagree.
What else would you get? What else? That's very, very critical, isn't it?
It is critical, but I honestly don't think the shortage of money is not the reason why people don't do things.
What is?
Look at what we have been able to achieve at St. Paul. It did not have the bells and whistles of this large amount of money. When people are committed and driven to bring change, when I look at the physicians that I work with at St. Paul, a lot of the faculty have given up significant private practice, NGO work, have sacrificed so much to come to a government hospital and work. So it takes sacrifice. It takes commitment. You have to have that vision. And of course, money makes it a lot easier to implement things, but you can have all the money in the world, and if you don't have a group of people who share your vision and who are willing to put the energy and who are not committed, you cannot accomplish more. So yes, money is a tool to get where you want to, and I think it would definitely enable us to shape our reproductive health agenda, be able to scale up training. But I think a lot of these things were already happening without the money. And I think the reason why our funders gave us the money is because they were impressed by the result of how much we've accomplished with very little money.
This is a fairly young institution, St. Paul, this medical wing of it. And you cannot for sure say this one is going to have a very long life. How sustainable is your program going to be in the years ahead? Are you sure about it? Are you confident that this is going to...
So the program, as in the residency scale-up or the reproductive health, well, we don't know.
The one that you started in this...
Yeah, the center. Yeah, so there are multiple things that are going parallel. So there's St. Paul, which is this amazing institution that has these young leaders that are committed. And I think it is in this projectile, that I have no doubt that it's going to be a leader in healthcare and research and policy in this country. I think it's an amazing institution that has our current provost, Dr. Zarihun, is a person who is in Mekelle leading, and he's really moved Mekelle forward at the university at IDER there. And he has big vision. He engages his faculty. He's young and he's determined. And I think with the young leadership, with the young faculty, I think we have momentum to move forward. And then there are these individual programs, program to scale up, OBGYN. I am very optimistic the program will be successful. Why? Not because, again, of the grant, but because people who own the program are committed. The young physicians, the young surgeons, and OBGYNs are committed to go out and recruit many more physicians to join their specialty, to improve maternal health, to improve access to surgical services. Ministry is committed. So when you have the commitment of the key stakeholders, there is no reason why the program will not succeed.
You are into family planning. You're very keen about it, and you're doing what you're doing, but also because you train along that line. But at the same time, you are, I understand, you are creating a new institution, a new facility within that medical school. That's a fertility lab. Here is a country that is 90 million plus in counting. I don't see
the connection.
The connection.
So you are not alone. For me, reproductive health is a spectrum. And it's having a choice to have a baby when you want to and not having a baby when you don't want to. If you look at the impact of infertility, there have been multiple studies, mostly from European literature, that shows that the impact of infertility is a lot more devastating in countries like ours, where children are valued so much in terms of inheritance, in terms of passing a family name, and in all aspects. So to say to a woman, yeah, I will help you plan your family, but I'm not going to help you have a baby because our population is too large, is quite unacceptable for me personally, morally, ethically. But I also am so happy because that's the policy of the Ethiopian government. I mean, there is no population policy. You can have as many kids as you want. We don't, force families to limit their children. But to be able to counsel a young adolescent girl or boy to say, these are the things you need to do. You need to prevent early pregnancy. You need to prevent sexually transmitted infection so that your blocks are not, your tubes are not blocked and you're not going to suffer from infertility. This is what you do to avoid unwanted pregnancy so that you have the opportunity to finish college like I did and have economic freedom so that you're not looking at somebody else for your livelihood. And then being able to say to that woman that I advise to delay childbearing because of her career, to say, it's okay if you're not struggling with infertility, we'll be able to help you achieve your goal of having a family, for me is a spectrum. It's one continuum, and I really don't see, it puzzles me that people don't see it that way, but you're not alone. A lot of people don't see family planning and fertility go hand in hand.
You're a lawyer, and you're a medical doctor as well. And I can see that you are very passionate about what you do. Do you feel that you have to give back? Is that what motivates you, perhaps?
I don't even look at it as giving back. I feel like this is home for me. I happen to be transplanted somewhere else. You
were not trained in this country as a medical doctor, and you would be at the bottom of the list in terms of coming back and do what you're doing. It's
I did not go to school here, but I've always also never considered myself to be permanently residing somewhere else. I always feel like this is home. So yeah, I am giving back. It's very rewarding, but for me it's not even about the reward. It's my mother, it's my sister, it's my brother, it's my community who's utilizing the service on a daily basis. But I'm also very fortunate, right? There are a lot of people who want to do this, but don't have the opportunity, don't have the support, so I feel very serendipitous in my life that I have an incredibly supportive husband who's also a physician, who says, go ahead and do this. My contribution will be to support you to do this. I have an incredibly supportive department chair. I have an incredibly supportive dean who not only make my absence from my work, part of the routine, but also throw their support so that, what we are doing is successful. But we also have amazing partners. There are many people who will start initiatives and either they just don't have the chemistry or there is no, reciprocal commitment and effort. I have just incredible partners.
And they have recognized your work, the Health Sector Award.
Correct, yeah.
Are you humbled by that?
I'm humbled. I am grateful. I don't know if I deserved it, but it meant the world that my work was recognized. But again, it's, I say this all the time, we get as much out of it as we put in. We bring residents, we bring partners. I have colleagues who come to Ethiopia and go back and say, we are questioning how we practice medicine. We're really wasteful. We don't need all this contact with patients. We do not need to dispose all this waste. So it's really a beneficial relationship, and that's how I pitch it to my colleagues in the U.S. We're not here single-handedly giving aid or supporting. We benefit from it. Our students benefit from it. Our faculty benefit from it. We have many faculty that are engaged in research. We have residents, medical students, and we do the same. We have students and residents and faculty who come from here. So it's a joint venture and one that's quite rewarding.
Well, I hope so, and thank you very much, Dr. Sennight. It was a pleasure having you on my show.
Pleasure was mine. Thank you very much.